Hey guys, this is Cesar with Nursing School Made Easy. Today's lecture is going to focus on pneumonia. So let's get right into it. Again, this is geared towards preparing you for the NCLEX exam. So I'm going to keep it very basic and as short as I possibly can. So let's jump into some causes right away for pneumonia. Number one, decreased level of consciousness or altered mental status. Okay, so decreased level of consciousness or altered mental status. This, for example, could be a patient that maybe is post-op. Maybe some type of overdose, excessive alcohol use. Possibly a stroke patient. Now, these patients are all going to be affected in a different way. For example, a post-op patient that had some type of sedation, the instruments that were put in, if they were intubated, again, if they had some type of surgery, the medication that was used is going to suppress the respiratory system. It's going to inhibit them or prevent them from coughing. It's going to prevent them from taking a deep breath in. Again, if they are confused, altered mental status, they have a high likelihood of aspirating. So aspiration is always a problem, as it is with OD, excessive alcohol use, or stroke. Okay, again, with stroke patients, you have to worry about if they're able to swallow. And so again, if they have any problems there, they can suffer from some type of aspiration. The aspiration, the contents, whether it's nasal, oral, or gastric contents, goes into the trachea. From the trachea, it goes into the lungs, and those again, aspiration contents will lead to a pneumonia. So again, that was number one, altered mental status by either a patient was coming out of surgery, OD, excessive alcohol use, stroke. Again, these are just a few to mention. Infection. Now this can either be viral, bacterial, fungal. We could even put chemical, some type of chemical that was inhaled, caused damage to the lungs. Now that typically wouldn't be infection, but we'll kind of group it in here also because that would cause some damage to the lungs. Smoking. It's going to change the lining of the trachea, the cilia that help move foreign particles. Okay, that lining is going to change because again, the smoking is going to kill off those cells, which allows for infections to occur more frequently. Some type of spread of infection. Maybe like a throat infection. Maybe patient was complaining of some type of sore throat, didn't go see the physician right away. The infection became worse and eventually spread to the lungs. Okay. Some type of intubation, endotracheal intubation. Again, you're sticking something foreign into the body, and you always run the likelihood or risk of that hardware possibly being infected. Maybe it's not completely sterile. Maybe the technique that was used wasn't completely sterile. Again, you're bringing something foreign into the body that raises the likelihood of an infection. In this case, you're putting this into the throat, into the trachea, that leads right into the lungs. Again, that can cause a pneumonia. Maybe something like an NG tube placement. Maybe some type of hospital acquired pneumonia. You had many sick patients. You went from one room to the next, didn't wash your hands appropriately, you didn't use the proper contact precautions, and now you've passed that infection to a new patient, which is again why it is very, very important for us to always wash your hands, use proper contact precautions for those patients that require it. Number 8, altered or decreased immune system. Now here we could run, for example, into patients that are elderly. As we age, our immune system decreases. Maybe this patient is on some type of corticosteroid therapy. Maybe they had some type of transplant. Again, if they had some type of transplant, they will most likely be on some type of corticosteroid therapy or immunosuppressants, again, decreasing their immune system. Other patients include patients that are receiving chemotherapy. And some type of cancer, again, they would be receiving chemotherapy, which again is going to cause decreased immune system. HIV patients. Now with HIV patients, the one pneumonia that you always worry about, that you must know for the NCLEX, we've seen in a lot of practice questions, is something called Pneumocystis jirovecii. Now, in most patients that are affected by this, it's no problem because your own immune system will rid your body of it. But in an immunocompromised patient or in a patient with HIV, this will cause severe problems. Pneumonia. So make sure you know this for the NCLEX exam. Again, Pneumocystis jirovecii. Now, for these patients, typically they will be treated with something like a Bactrim or Septra. Okay, again, this is found in immunocompromised patients. Something else could be an infection with cytomegalovirus. Now this is a virus, hence the name cytomegalovirus. This is part of the herpes virus family. Now this is a viral pneumonia, and we talked about how you may have bacterial, fungal, or viral pneumonia. So in this case, this is a viral pneumonia. Now this is typically seen in patients who had transplant, some type of organ transplant. Okay, so if you have a patient, again, that had some type of transplant, one of the things that you worry about for these patients is cytomegalovirus infection, pneumonia. Okay. Now, what will be some clinical manifestations? Just misspelled that. What will your signs and symptoms be? Number 1, fever, chills, shortness of breath, very important here. Productive cough or rust colored sputum. Very important for you to know for the NCLEX, okay? Rust-colored sputum. 5, chest pain. Confusion or altered mental status. This will most likely be due to hypoxia. Crackles. So again, if you were to auscultate, most likely find crackles in the lungs. Body aches. Now, how exactly does all of this occur? Let's make a quick drawing here. Say that this is our face. This is our trachea. And remember that your trachea is going to bifurcate. And we'll get your bronchi. And these will get smaller and smaller, smaller, until we get to some point where you get alveoli formation. Now remember that oxygen exchange will occur at the alveoli. Okay? Now I'm again making these very, very big. They do not appear this size in real life, but I'm just trying to explain something here. So when you get a pneumonia, an infection, you'll get bacterial, fungal, viral infection organisms coming here to your alveoli, residing here. Now as a result, a couple of things will happen. They'll begin to infect, cause problems, and fluid will begin to accumulate. Okay? Fluid will begin to accumulate. Now your own immune system will kick in, and it's going to send some soldiers, some officers to come in and start taking care of the infection. First ones to arrive will be your neutrophils. They'll come here and start taking care of problems. They'll start gobbling up whatever's present. As a result, more fluid will accumulate. And this will happen, depending on how bad the pneumonia is. It may happen to a complete lung, to part of the lung. And so these become, again, fluid-filled. Now, if these become fluid-filled, air exchange cannot occur. And as a result, you become hypoxemic. As a result of hypoxemia, you can have confusion, altered mental status. You have more pressure in your chest. This can result in some chest pain, some congestion. Again, this will cause chest pain. The fluid accumulation will result in crackles if you auscultate. Now, at some point, again, you're going to be coughing up this material. So when you cough, you're going to bring it out, spit it out. So you will have a productive cough. Infectious, so it will be rust-colored. The sputum, again, will be rust-colored. Now, again, we talked about how these will be fluid-filled. That will lead to a shortness of breath. The infection will result in fever, chills, body aches. These are very, very simple clinical manifestations, signs, and symptoms. Okay, so what are some complications that we must worry about? Number one, if this fluid accumulation continues and isn't resolved, you will end up with something like a pleural effusion, or fluid in the pleural space. Now, depending on how bad the pleural effusion is, it may resolve on its own with some medication, antivirals or antifungals or antibiotic therapy. If the fluid accumulation is severe enough and is impeding oxygen to be exchanged, if the hypoxia is severe enough, then something like a thoracentesis may be performed. Again, the purpose of the thoracentesis is to remove that fluid to again help the patient breathe. Number 2, atelectasis. Now, the atelectasis just means a collapsed alveoli. Think about a grape. I want you to picture a grape right now. What would happen if you were to squish that grape? It's going to collapse. Well, a similar thing can occur to these alveoli, and they can become collapsed. So for these patients, you want to tell them to cough and deep breathe. It'll make the the alveoli reopen up. Okay, so for these patients that are suffering from atelectasis, cough and deep breathe is very, very important. So your IS is very, very important. Again, you want to prevent atelectasis. Number 3, if the infection is not treated, something like bacteremia can occur. So bacteria in the blood and circulation. Okay? Now you always worry with sepsis if this occurs, especially with elderly patients or immunocompromised patients. Bacteremia, again, that's bacteria in blood. Empyema, or purulent fluid in the pleural cavity. And again, we talked about how neutrophils are going to come in here, start phagocytizing these microorganisms. As a result, pus will be formed. Again, that's what empyema is, purulent fluid accumulation. 5, if again, remember where your lungs are, also remember that around this area you're going to have your heart. Okay? Say that this big structure here is a heart. If the infection begins to work its way around and begin to spread, the infection can then affect the heart, and something like pericarditis may result. This pericarditis would increase chest pain. So both pericarditis and endocarditis can occur. So again, the heart is being affected now because of the spread in the infection. And if the infection again continues to spread, it can also travel to the brain, causing meningitis. So what are some diagnostic studies that you need to know for the NCLEX exam? Number 1, chest x-ray. Now again, this is just a plain film chest x-ray. Something else like a CT chest can be done. Okay, but most important of all is chest x-ray. You can do sputum cultures. You can also do blood cultures, especially if you have something like AMS, altered mental status. If you have confusion, then you're always wondering, well, has the infection spread? Is there anything like sepsis? If there is sepsis, you want to know exactly what type of bacteria, what type of pathogen, virus, fungus is causing the infection, and as a result you would do blood cultures. So that was 3 and 4. You'll do a CBC, and the CBC will look at the WBC, white blood cell count. Now in most cases you will find this to be elevated. More specifically, your neutrophils will be elevated, and on your CBC these will appear as your bands. Okay, so your bands will be increased. Again, your body is sending more, we'll call them officers or neutrophils, because there's an infection going on, there's a crime scene occurring, so your body's going to start making more neutrophils. It's going to start making more officers, and as a result your band number will increase. Now, something that you need to remember if you're going to be doing any type of cultures, sputum cultures, blood cultures, you typically want to make sure you get these things before you start antibiotic therapy. Okay? So if you're able to collect these before you begin therapy, that is best. Now, what are some interventions that you would do for your patient? If your patient has any type of altered mental status, if they're confused, if they had a stroke, you either want to place them in a sideline position or an upright position. Okay, the goal here is to prevent aspiration. Again, if your patient has any likelihood of getting seizures, you want to put them in a sideline position. Any stroke patient, again, sideline position. If not, semi-upright or upright position. Again, you're trying to prevent aspiration. You will turn and reposition your patient every 2 hours at minimum. You will ambulate your patient. And this is very, very important if it's a patient that is post-op. You want to get them moving. You want to get them breathing hard. You want to get them to take deep breaths in. So ambulating is going to help. Again, you're trying to prevent atelectasis, or a collapsing of those small alveoli. So you will also encourage IS. You'll tell them to cough and deep breathe. This is very important, again, especially with post-op patients, post-intubation patients. Again, any patients with NG tubes, you want to prevent aspiration. So same thing, you want to make sure that the head of bed is at a 30 to 45 degree, brought up 30 or 45 degrees. You do not want to put them in a supine position. Again, you're trying to prevent aspiration. Now, for example, if this patient has something like a gallbladder removed, some type of abdominal surgery, anytime that they take a big deep breath in, it's going to cause pain. If your patient is in pain, they're less likely to take deep breaths in. So you want to make sure you have adequate pain control. But as with any time that you're giving pain medication, you always want to assess their respiratory rate. You want to make sure that you do not give too much pain medication, because at that point you will begin to sedate your patient, okay? So you give your pain control, make sure that it's adequate pain control, but you always want to assess your patient, make sure you're not giving too much. If, for example, any type of tracheal suctioning will occur, especially for intubated patients, you want to make sure that you always use a sterile technique. Right. We talked about how with immunocompromised patients, you have to be very, very careful. You don't want to introduce any infection from another patient to them. So you, as a nurse, make sure that you're always washing your hands. Note that backwards. Okay? This is very, very important. For example, somebody who is receiving chemotherapy, cancer patient, if they're immunosuppressed, you'll want to make sure that you gown up, wash your hands for their protection. So good hygiene. Other things are, you want to hydrate your patient. So IV fluids. You always want to assess their O2. If it is low, then some oxygen therapy may be required. You want to inform them of nutritional therapy. Now this is very important for elderly patients. Okay, you want to make sure that they're taking enough protein in their diet. Now with your patients, you always want to tell them to complete or finish all their antibiotic therapy, whatever medication that they're taking, make sure they complete it, make sure they finish it. A lot of patients will stop taking their medication after maybe a day or two. They might get a little bit of relief, fever goes away, coughing stops, and they stop the medication. Well, that is a problem, because if they stop the medication, that still allows for some of those bacteria, viruses to continue causing problems. Now the problem becomes, or the problem rises when those organisms build immunity to the medication that you're giving that patient, excuse me. So again, you always want to make sure that the patient knows to finish their drug therapy, whatever medication they're on, because again, we want to make sure that we rid the body of whatever pathogen organism is present. Last but not least, you want to inform your patient of the pneumonia vaccine. Now remember that patients can get the pneumonia vaccine if they are at risk for pneumonia, and that revaccination will occur in 5 years. Okay, so if they got it at age 50, 55, then they would get or need to be revaccinated at age 60, 65. Okay, so revaccination occurs in 5 years.